It's my great pleasure to be here to host the next panel session in what is the 50th year of PSI. I'm not exactly sure how many conferences there have been, but certainly this is the first online virtual format one. And before we go any further, I do just want to pay particular mention to and credit to Lisa Stafford, Mark Smith, the folks here at DV4 Studios, and indeed the rest of the PSI Conference Committee for putting this together and ensuring that we get to have a conference this year in the current circumstances. So, Mila Buikas. Two other things to mention before we go any further. Any tweeters amongst you, and I know there are likely to be some, I see you. If you are commenting on this particular panel session or indeed in relation to anything to do with the conference, if you could please use the hashtag PSIConf2020, that would be most appreciated. Also, if anybody has any questions arising from the presentations that the folks will run through in the next few moments, please use the Q&A function as opposed to the chat function. It's just important to bring that to your attention too. So without further ado, let's get started. I'm Damien Lowry and I'm honoured to be your chair for this particular session, a session that's going to be discussing the psychological impact of COVID-19. It's a panel discussion based on a document that was put together by the PSI Science and Public Policy Committee earlier this year, and some of the committee members are here this morning to present on its contents. Briefly, Dr Annette Burns, Ms Kathleen Halligan, Dr Dean McDonnell and Professor Brian Hughes. First up is Dr Annette Burns to present on two talks, the first of which is the psychological impacts of COVID-19 at the individual level. And Annette is the Interventions Officer for Loneliness at the Institute of Public Health since 2018 and the Visiting Research Associate at the Bamford Centre for Mental Health and Wellbeing at Ulster University. She is currently conducting a programme of primary and secondary research on loneliness funded by the Institute and Ulster University, which focuses on older adults' experience. Previously, Annette conducted research around mental health and smoking and was a scholar on the SPHERE programme, which provides structured PhD training in population health and health services research. Over to you, Annette.
Well, thanks so much, Damien, and good morning, everybody. Thank you for that introduction, and also thank you to PSI for the opportunity to share this work by the Science and Public Policy Committee this morning. We made the decision back in April, with the support of Mark, to pause our current work plan to see how we as a committee might be able to support PSI's response to COVID-19. And we were delighted to be able to publish the briefing document, Psychological and Mental Health Needs Arising from COVID-19, as a result in August. And just in developing the document, just to explain to you, what we did was we looked at the literature emerging around COVID and associated measures, but we also looked as well at the previous literature and the lessons we could take from that perhaps more established literature on previous outbreaks and disasters and catastrophes as well. So we ended up then with a document that was based on evidence across sectors and disciplines and countries. And today we're going to outline the evidence in that document, but we're also going to provide, where we have it, updates on evidence that's come out since then, because obviously we're all in a very rapidly changing situation at the moment and we're all very much learning as we go. So we're looking forward to that, and also we're looking forward to, at the end of our presentations, the opportunity for further discussion and indeed your questions and comments. I should just mention as well that, as we state in our document, this is not, of course, an exhaustive list of the potential impacts that we may see, and it's also not possible for us to be clear on the causes of these impacts. So obviously there's going to be quite direct impacts in terms of the virus and illness and loss of life and grief associated with that, but there's also going to be the social and economic effects associated with the measures that we've needed to take in order to limit the spread of COVID as well. And so I'm just going to kick off today and talk about the first two sections in our document. So that's the psychological impacts at the individual level, and then I'll also move on to talk a bit about loneliness and COVID-19 as well, before I hand over to my colleague. And when we published our briefing document, the initial studies were reporting widespread distress across the general population, and there were specific reports of anxiety, depression and PTSD, and we were seeing this distress reported across several countries. And there were also reports of reductions in life satisfaction, satisfaction with personal relationships, and increases in things like nervousness, loneliness, and feeling downhearted or depressed. And as I said, we've noted that the difficulty is in identifying the drivers of these experiences, and the research at the time was pointing to them being associated with factors related to the virus itself in terms of infection fears and the impacts of bereavement, but also factors related to the measures taken to limit the spread of the virus. So things like quarantine duration, frustration and boredom, inadequate supplies and information, as well as financial loss, and then the breakdown of social support structures too. And since the publication of our document back in August, we've seen further evidence around this in terms of direct and indirect impacts. We had a recent Lancet paper which got a lot of attention in the media, and that was reporting on the high incidence of psychiatric diagnoses in patients in the US who'd been diagnosed with COVID. And there was an incidence rate of 18%, and also a rate of almost 6% in terms of new psychiatric diagnoses, so patients who had no previous psychiatric diagnoses, which was also about double that seen in patients that hadn't been diagnosed with COVID. So that is definitely something to be concerned about. And this was all based in the 3 months since COVID. Also, the authors of that did mention that this could be related to the physical effects of the disease, but also the stress around the disease. And interestingly, they also noted that people with a past year psychiatric diagnosis were also at increased risk of getting COVID as well. And this may be due to confounding factors like socioeconomic status, but we don't really know. So that's the US. In the UK, we've also seen reports of increased psychiatric urgent and emergency interventions overall since COVID arrived. And we are also seeing evidence that COVID is being noted as a factor in psychiatric admissions as well. So evidence from Northern Ireland has reported that in 30% of psychiatric admissions, COVID is being noted as a factor. And this is again coming in directly in terms of health anxiety, but also and much more frequently indirectly in terms of financial pressures and loss of support from family, friends or services. On a more positive note, though, there's also some evidence emerging that the general distress and lower life satisfaction, etc., among the wider population, there is some evidence that that might be settling or leveling off somewhat. And it doesn't look like it's returned to pre-COVID levels, but it certainly does seem to be slowly declining over time. But regardless, I suppose we can clearly see that there's knock-on effects at the moment, and only time will tell how big they really are and how long they will last, because there's probably quite a lot of potential lag with a lot of this. But either way, I guess it's of particular concern for systems that were already overwhelmed and struggling to meet the demand even before COVID. In terms of some of the particular risk factors for these psychological impacts at an individual level during COVID, age appears to be an important one. And several studies now seem to indicate that older adults may be a bit more resilient to the mental health impacts of COVID, even though they are at increased risk, of course, in terms of the complications of COVID itself. And of course, we do need to take account that a lot of the surveys happening at the moment are online, and there is a digital divide. And it could be that the older adults who are online are the ones who are also doing better. But even in a non-online population representative study of older adults in the Netherlands, they did see that mental health appeared to be pretty stable in older adults and resilient. So they had data in May 2020 and compared that to 6 months before, which would have been pre-COVID, and they saw that mental health was pretty stable. And we've also seen numerous other studies and national statistics now from various countries supporting this in terms of well-being appearing to be less affected, at least proportionally, in older adults, or greater resilience to these psychiatric disorders associated with COVID, and lower prevalence of feeling down. And some of this research talks about how this may be because older adults typically display lower reactivity to stress, exercise more effective regulation, have perhaps also greater experience of being alone and with life-threatening medical conditions as well. So some of this may be playing a part. Young people, on the other hand, appear to be less resilient at this time, or perhaps we should say disproportionately affected. We've seen, for instance, that in younger adults, there's less of those improvements over time in depression and anxiety symptoms. We've also seen reports of higher prevalence of thoughts of self-harm and death in young adults than older age groups. And I think it's perhaps not surprising we're seeing this given the huge shift that young adults have had in their day-to-day life and the stage they're at and all the things that they're supposed to be doing right now, both developmentally and socially. And the fact that, pardon me, a lot of this has been disrupted by the situation we're in, and a lot of it has had to kind of go on hold. Also the fact that young adults may also, many of them, be in more precarious work situations as well, which I'm sure Kathleen is going to talk about that in a little while. And beyond age, then, other risk factors for doing less well at this time were existing mental health conditions since before COVID, long-standing conditions in general, living alone, greater deprivation or lower household income, being female or being a caregiver, all appear to be associated with poor mental well-being at this time. And we also, in our document that was published back in August, noted the impacts on another key group in terms of frontline medical staff. And we had seen in the literature reports of anxiety, depression, insomnia and distress, with the impact appearing to be most pronounced in women and nurses and those working in the virus epicenters. And since then, we've seen the publication of a Cochrane special collection on interventions that may help healthcare professional well-being and reduce stress during COVID. And these included interventions for occupational stress, which focus on resilience, but also on a more basic and practical level, perhaps interventions for physical safety and capacity to work. So things like ensuring people were getting their breaks, which I think kind of highlights and perhaps just reminds us all of the point that this is not a normal situation at all, and increased distress is not uncalled for, but I think it's about what might help and keeping an eye on this, and particularly keeping an eye on the groups that seem to be at the most risk right now, including our frontline workers, younger adults, and those with pre-existing mental health conditions as well. And linked to that, I suppose another key risk factor for our mental well-being is, of course, loneliness. And loneliness was the second kind of topic we looked at in our document. And loneliness is, as we know, not the same thing as isolation. And in fact, the two are only weakly correlated. So it's possible to appear quite isolated and be fine, and likewise to be surrounded by people but experiencing a lot of loneliness. And as we noted in the briefing, research on loneliness has tended historically to focus on older adults. But of course, loneliness is not exclusive to older adults, and the majority of older adults are not chronically lonely. And in fact, just before COVID, I think we were starting to become aware of the high prevalence of loneliness in young adults, which may be even higher than the rates seen in older adults. And we noted that the initial evidence around COVID was also indicating that it was young adults that were seeing the highest levels of loneliness at this time. And since our document was published, this has remained the case. We have a lot of studies and national data from various countries now indicating that young people are most affected at this time in terms of loneliness. However, as I mentioned in relation to mental health and distress, a lot of the data that we have is coming from online surveys. And it may be that older adults that have access to this are, as I say, the ones that are doing better at this time. And we see some evidence of that from that population Netherlands study that wasn't limited to those online. And they showed that in the 6 months before May 2020 and after COVID arrived, that there was an increase in loneliness scores among older adults. So while their mental health actually appeared stable and resilient, they did see an increase in loneliness. And interestingly, the loneliness they saw was reported to be associated with personal losses, but also worries about the pandemic and a decline in trust in societal institutions, which I think is a good reminder to us that loneliness is quite complex and broad and not just about isolation. In terms of these increases in loneliness and why that's important, well, we know that loneliness is associated with poorer health outcomes, both in terms of physical health and mental health. But oftentimes we don't have that much clarity on the directionality of these associations. So whether it's that people with poorer health are at increased risk of loneliness, or whether loneliness itself leads to poorer health. And we need a lot more evidence on those associations. One area in which the evidence is particularly strong already is in terms of depression. And we know with depression, it is a bidirectional relationship, but loneliness is stronger as a predictor of depression. And so that's something we do need to be concerned about beyond just the negative experience of loneliness itself. And so it's important that we need to keep an eye on these trends and also an eye on the groups who appear to be most affected. So young adults, those who live alone, those with pre-existing mental health conditions, and those at lower education or income. And just to note also that a lot of these risk factors are the same as the risk factors for loneliness before COVID as well. In terms of what we can do, unfortunately, the interventions that we can do at the moment for loneliness are of course limited, but so unfortunately is the evidence on their effectiveness. And there's a real lack of evidence on the effectiveness of interventions for loneliness in general, but there's also a lack of evidence on how well things like video calls work for loneliness. And we need a lot more high quality randomized control trials to establish this. And I suppose related to that and the lack of a strong evidence base on loneliness interventions is another issue at the moment before we even get to interventions, which is the varying ways different studies and statistical offices track loneliness. So some people look at those who are lonely always or often. Others include people who are sometimes lonely, or even those who are lonely a little of the time. And sometimes we just simply get large group data representing all these people. And so there's a lot of variance and nuance in how it's reported that can be lost at times. And it does seem perhaps a small thing, but it's really important that we have consistent definitions and measurements so that we can track loneliness meaningfully and we can make comparisons across data sets as quickly and easily as possible. Policymakers and everybody at the moment are obviously overloaded with information, so it needs to be, I think, less cognitively draining to figure this out. And just to finish up, overall, in terms of the most worrying and intense type of loneliness, so that is those people who report that they are lonely often or always, and the population level changes in that. Well, looking at UK data, the usual pre-COVID prevalence of being lonely often or always was 5%, and at the beginning of lockdown it was actually the same, 5%. And the very latest data shows that it's currently 6%, although it did reach a height of 8% there just at the start of November, and that's the statistic that was talked about in the media yesterday. But overall, I think looking at this, there is reason to believe that chronic loneliness has not consistently increased population level at this time in the UK, and that perhaps provides us with some hope in general, I think, in terms of loneliness at this time.
Okay, thank you, Annette, for two riveting presentations and plenty of food for thought there. And we might have a couple of questions later on. I saw one or two come in, so hopefully we'll get to field those in due course. Next up is Miss Kathleen Halligan to present on work and organisation impacts of COVID-19. And Kathleen is a seasoned HR and talent development strategist. She has worked in-house as a consultant for over 25 years in senior organisation design and executive development roles, both nationally and internationally, passionate about enabling organisations, teams and employees to perform optimally. Kathleen uses evidence-based and innovative practices grounded in psychology to help deliver the desired outcomes. So over to you, Kathleen.
Hi, Damien, thanks. And as Annette said, thanks, Annette, for your piece, and delighted to be part of today's session. I think particularly when we look at the impacts that COVID-19 has had in the space of work and organisational psychology, what the existing research in the whole area of work and organisation, I think is helping us understand a lot of the reactions that are being evidenced as a result of the impact of lockdown and such things. And I suppose if we start from the point of view of what was the impact on the individuals and the organisations, the first thing to say up front, in terms of organisations and people, an organisation is a collective of individuals, and even the responses or the reactions that Annette was speaking about there, any and all of those can happen to people variously depending on their own personal makeup, their own personal circumstances and that. So it's just very important to note that it is very difficult to generalise in any of these areas. But in the first instance, if we bring ourselves back to March, when we got the notice of lockdown, the first thing that happened fundamentally for everyone is how people did work changed, how people work. So whether that was you'd no longer any work, or where you went to work, you now had to reorganise how you work together, social distancing, you went into the pharmacy, there was polythene up, you know, all these sort of things changed about people who were still going to the workplace, how they interacted together. A lot of people were sent home to work, and some people had been looking for this opportunity for a long period of time, and now it was being afforded to them without any challenges, but well, as in they weren't having to go look for it, but now you're being sent home, but have you now got the facilities to be able to do that? For frontline workers, the expectation of them in terms of their delivery became a lot more intensified, because again, if you were in the healthcare settings and that, you fundamentally changed how you had to go about operating. So just even in how we went about doing our work changed. And interestingly, and all the factors that that Annette was speaking to there that could affect people individually, as a collective, what we actually saw in the early days was a collective behaviour, which is quite representative of what happens in a time of a disaster or a catastrophe, where people start working as one because, hang on, we're all in this together. It's not just my organisation, my department. Everyone has been asked to stop doing what they were doing the way they were doing it and changing it. And so you saw people acting quite heroically. Okay, let's get in together. Let's change the workplace. Let's look at how we can still deliver the services that we were doing. We can still keep the show on the road. People were going the extra mile, wanting to be part of the solution. So a lot of that is that behaviour that you see in times of disaster or catastrophe. But then with time, we start to adjust to the new way of working. And then things like home commitments, care for dependents, recognising that my old routine is gone. And again, research around the dependence, if you like, that we have on routine really comes to the fore. People realising that, so people experiencing things like fear, stress, anxiety, loss, coming from the fact that my brain has suddenly realised we had a way of how we like to do things, that's no longer there, and I don't have a consistent pattern of how I'm going about organising my day, and realising that it's important for me to reinstitute a routine in order to simplify, you know, my everyday interactions. So people being able to get that new routine, to create a workspace, became very important. And so again, linking to pieces that Annette was talking about as well, like loneliness was a topic, but what people in the early research are reporting, this notion of social isolation. So it's very interesting if you think about the concept of where people had to go home to work. So for some people, that's nirvana. This is what I always wanted. I can now go to a place where I sit down, I can concentrate, I don't have people coming up interrupting me, versus other people who are inherently social or extroverted, if you like, in their preference, and they no longer have that opportunity to swing around and ask a question to the person who sits beside them or to bounce ideas off them. So those senses of loss are coming out. So what people may have struggled with in the old world, they're now finding easier in the new world, and vice versa. So again, you know, the research around personality, around preference, and that can help us understand the varying responses that people are having to the new world of work, if you like. Interestingly, things like people, the one thing I will say particularly within this discipline, that this situation has created a vast number of areas to now probe for further research, because without a doubt how we work into the future is going to change, and for a lot of people that may be a blended work approach, particularly for people who would traditionally go to an office and work from there, but they don't necessarily need to do that. And so that there's great opportunity to look at what are the factors that are enabling that, and what are the ones that are making that more challenging. And again, a lot of the existing research can help us understand the pieces that are most impactful in that area. Particularly, there's work being done looking at the impact of people's availability to flexible working options. But interestingly, what the research is showing, that whether that is their formal arrangements or informal arrangements, and a lot of what the COVID response has brought about in people is that they maybe people who've been looking for empowerment over time have been given that empowerment automatically, and so the informality has happened organically, if you like, and the evidence would suggest that informal arrangements are much more conducive to building employee engagement, to improving individual performance. So we certainly we've a lot to bring from the existing evidence into how we go about organising the new world. And I think also things for organisations to think about, the areas of organisational culture, things around connectivity. So some of the great enablers in this particular crisis has been the technology. Had this happened 10 years ago, you know, would we have been able to have this online conference? You know, and would people have been able to go home and effectively, you know, continue work with very little, in many cases, very little impact on overall performance? And indeed, some organisations are reporting, you know, people performing above and beyond what they may have done in the past. So, you know, there's great benefits to come out of that, but then on the counter side, you have the challenges of people struggling with being able to disconnect. So now that all this connectivity is there and people can reach me through various means, do they know when to switch off? And without a doubt, I think from the work and organisational context, the big pieces that can help in transitioning in this is understanding personality styles and preference, and being able to recognise individuals, you know, how to get the best out of individuals in that context, how to get the best out of technology in that context. And I think without a doubt, the idea that taking time out and realizing that when we do stop and take time out and engage the cognitive brain, we can adapt very quickly to new situations. And I think a lot of organizations have learned this ability to pivot. So where in the past there may have been pushback to how am I going to, you know, we couldn't possibly do our business that way. Now that we've no option to look at, you know, how we're doing it, we come up with new and great ways of adapting. So I think just from, what can we learn from this and what are the things that can help, without a doubt, and again linking back to what Annette was saying there, the piece around psychological capital, so resilience, optimism, hope. So really skilling people up in those areas to support them in terms of how they can transition in these times, and then that's helping people at an individual level and then at a team level, tapping into team effectiveness. So how we go about building satisfying relationships within the team, team cohesion, agreeing how we can coordinate as a group. And there are a lot of interventions out there that can support people in that way. So there's a huge amount in this space, and without a doubt we will see, I think, as a result of this, an awful lot more practical-based research that can back up some of the theories that already exist.
Thank you, Kathleen. And thank you both, Annette and Kathleen, for sticking to the time limit so far. I guess that just gives the two remaining speakers their allocated time too, and I might ask politely that they try to stick to their time limits too, just so we have a few moments at the end to ask questions. So next up, and without further ado, is Dr. Dean McDonnell to present on the impacts on third level education. Dean's post as lecturer of psychology at the Institute of Technology Carlow sees him teach across a range of modules related to applied psychology, early childhood and social care. He has a range of research experiences, such as completing a 2-year postdoctoral post in Dublin City University, DCU, where he utilised eye tracking and multimedia analysis tools to explore executive function, multimedia contexts. Dean is currently working with a team of psychologists from the American Psychological Association, the British Psychological Society and the PSI surrounding screen time and child development. So over to you, Dean.
Thanks a lot for that, Damien. I will try my best. I will set my timer as well, just to keep things on track. I think a large portion of what I'm going to mention as well, just a caveat in addition to my colleagues there, is that we're still trying to find a lot of evidence and lots of research, and because a lot of the studies can be very much self-report, it's very difficult to find concrete evidence surrounding different things too. From an educational perspective, especially when it comes to third level, we're still in the middle of trying to grade some of the first assignments from this particular term, so we still may not know a direct impact in terms of the successes of academia, for example, or just in how direct COVID might have affected just different grades, for example. So there's still quite an awful lot of things that we need to try and figure out. But in terms of the initial documents, a large focus of this was trying to look at the safe return and trying to plan the transition to digital learning, especially when we're looking at the last couple of weeks of term. And there's been quite a few studies that were conducted. Crawford, for example, was one, Crawford et al. And a large proportion of that study was looking at trying to compare, I think it was 20 different countries and their response to this shift to digital learning. So they were looking at the goods and the bads, essentially, of this kind of the technological infrastructure. And in Ireland especially, it's been quite good. Like over the summer, a large number of universities very much up to their game, and quite an awful lot of teaching and learning committees that are in respective colleges worked tirelessly over the summer as well to try and ensure that staff were adequately trained to be able to deliver quite an awful lot of online content, and created videos, created lots of resources for students as well, to try and prepare them to try and deal with it. Like, I know there are quite a lot of universities that do offer quite a lot of blended learning programs, but the traditional platform of face-to-face teaching is still quite the norm in a large portion of Irish universities. But this obviously has changed once September hit. I know there was some hope of having some face-to-face classes by this time, but I know with the second lockdown, etc., that has kind of put things on a bit of a question mark in terms of when. So we are very much still responding with responding. We're trying to be as reflexive as we possibly can. But again, I was trying to find a couple of studies that were carried out, and there's quite a number actually. Gonzalez, for example, is one who was looking at academic performance in Spain, and they were finding that because people might have been stuck at home for quite a large portion of time, that they found some slight increase in academic performance in some tests. So there are some studies, again, just to caveat that as well, Gonzalez et al., it was quite a small sample. Additionally, there's quite a lot of research coming out of the States to show that there is some increase in academic performance. And because their term is slightly different to ours, there are some countries that do show some evidence of higher academics and higher academic achievement. But that is to say as well, these countries are also showing slight increases of anxiety and depression and other kind of negative cases as well. So we do need to try and find a balance in some form. There's quite a lot of studies here, though, trying to keep it closer to home. For example, one by Yolanta Burke has provided quite an awful lot of et al. Research in terms of the response in primary schools. There's also in terms of post-primary by Moen et al. In terms of second level education. Brunson et al. As well was looking at the push and the response in terms of online learning. Then there's Hylands et al. As well from NUIM, focusing on anxiety and depression, and I think a lot of the research from them is ongoing too. And then Hylands and Howland as well et al. From DBS is currently undergoing quite an awful lot of research too in terms of very similar areas, looking at the response. Myself and other colleagues in IT Carlow and other places too are still looking at these responses. So a lot of research is still currently ongoing, and there's still quite an awful lot of things that we don't yet know, but we are in the middle of trying to find just different solutions. In terms of other aspects, when trying to look at things like motivation, there's some research coming out of the Netherlands, and again, slight caveat in that it's quite a small sample of 166. There's some research to show that there is a slightly higher kind of rates of lower motivation. There's lower time investment as well with some students. Like we know from a lot of research over the last number of years that transitioning from primary school to secondary is quite stressful. We know that transition from secondary to college and university is quite stressful too. And coupling that with COVID-19, it just adds quite an awful lot of layers in terms of commitment, in terms of just uncertainty as well, which could be quite difficult. There's other stuff as well in terms of teaching practice. So if you're to look at how the traditional classroom, maybe the kind of the direct instruction, more behaviorist approaches as well, or this kind of traditional idea of chalk and talk, like there's so many other practices that we can't necessarily do. Like some of my classes, for example, I would have printed out papers and was able to go to each of my student groups and say, let's break this study down and let's try and figure this out. Naturally, we can't do that now. So we do have breakout rooms. We are trying our best to try and facilitate different methods. Again, teaching practices and learning styles are going to differ. So there is quite an awful lot of flexibility needed, and there's still quite an awful lot more work to be done in this area too. In terms of ways to try and track attendance, this was one thing that we used to, that I found quite useful in terms of seeing students face to face. You could actually see how they were getting on. You could have that kind of interpersonal interaction. And that's one thing that I have tried to do and incorporate as much as possible to try and encourage that few moments before class and even a few moments after class where we can actually have a bit of a human dialogue, essentially. So not just content, that we're trying to balance the personal aspects. So trying to facilitate some time for that. There's also other aspects in terms of, again, looking at engagement. There's quite an awful lot of research there as well. So again, looking at YouTube clips, trying to break it down, even trying to set some other tasks. During the time of year, especially after Halloween, there's some research to show too that there is a slight dip in terms of motivation, that again some illness might come in as well. Like fresher fever, I think was one thing that came up in one of the studies, that there is this natural tiredness between Halloween and the Christmas kind of era, between that kind of period of time. And that's still seen here as well. There are some studies that are showing that there is going to be some fatigue, and coupling that as well with other just basic interaction with other people as well. We don't have quite an awful lot of that too. In terms of other things such as education providing some element of normality, we still don't know what kind of a huge influence this is going to have. And again, Kathleen mentioned quite a few there. Annette also mentioned couples there as well. And more research is going to be coming up too with Brian in terms of some of these factors. But other than that, if there is any other research that's currently undergoing, or if you are involved in any research, I'd really like to know about it. So myself and other colleagues have been looking at academic responses. So one of which, with Maeve Murphy in IT Carlow, what we were looking at was different factors that are influencing COVID-19 and how it might have responded. But one thing that a few studies haven't looked into, but we're kind of looking at now, is how a lot of people at home have multiple caring roles. So some of our students actually have families, some of them have children themselves, how lecturers and other academics also have children themselves, that it can be very difficult to try and find a safe space to be able to teach a class without any disruptions. And with other research with Mark Smith as well that myself and him are carrying out, one of the preliminary findings was that some therapists, some psychologists and their clients are finding it difficult to find safe spaces as well. So there are lots of overlaps between education and other areas of psychology, and we still need to carry out as much research as possible in trying to understand lots of the little factors that may be influencing. So I'd be more than happy to have a discussion with anybody who would be interested in kind of collaborating on some projects, or even if you are involved in some, definitely get in touch. I'd love to hear more, because there's so many things going on. I'd love to try and keep some stuff as close to home as possible to see how we're actually getting on.
Okay, thanks, Dean. Like Annette and Kathleen before you, some very thought-provoking points in all that. I think what might distinguish you from the previous speakers is that you're clearly a botanist as well on the side. At least you're advertising yourself as such. But we might come back to that in the Q&A session. So moving on to our next speaker, final speaker, but Professor Brian Hughes is going to present on two separate topics, so he might roll them back to back like Annette did at the outset. The first topic being the economic recession, financial threat and unemployment, and the second talk focusing on longer-term psychosocial impacts that are associated with catastrophes, emergencies and upheavals. Brian is a professor of psychology at NUI Galway and a specialist in stress psychophysiology and health psychology. He's a fellow of the PSI, served as PSI president in 2004 to 2005, and received the PSI Members Award for Research in 2019. Brian writes regularly on the public understanding of psychology and science, and on the relevance of psychology to social issues. His books include The Psychology of Brexit, published in 2019, Psychology in Crisis, 2018, and Rethinking Psychology in 2016. His widely read blog, The Science Bit, is at http://thesciencebit.net. I'm sure you'll be able to find it, despite my efforts to the contrary. Over to you, Brian.
Thank you very much, Damien, and thank you all to the other speakers as well. And as has been outlined, when we were doing the document, one moment here. When we were doing the document, we wanted to identify the areas where we could bring scientific research to bear on the COVID crisis, and not necessarily isolating COVID research, but also looking at broader research areas. And the two I'm going to talk about will be the impact of, say, economic distress on mental health and mental well-being. And then the scientific literature, the second topic, will be on the areas of, say, disasters and catastrophes, as has been mentioned. Okay, so the first topic essentially relates to economic factors. And undoubtedly, the COVID crisis creates a severe economic impact on the economy. So I'm going to talk a little bit about this in relation specifically to the research on past recessions, but also the research that links unemployment to suicide. And then I'll have a little discussion about the ripple effect on mental health that we see in relation to economic factors. You might be aware that on the 7th of September this year, Ireland officially entered recession. Recession, as you probably know, is defined as 2 consecutive quarters of negative growth. And in the second quarter of 2020, Ireland's GDP shrank by 6.1%. That's the second consecutive fall, but it's also the largest quarterly fall ever recorded. So we are certainly in recession. We're in a major recession in a very short space of time that nobody saw coming this time last year. The ASRI issued a report in October doing some projections on the statistics, and they predicted that while some parts of the economy, like the medical sector, unsurprisingly, were very active, other parts were not, and overall GDP is going to decline this year. A little bit better than they thought, but nonetheless it's going to decline by close to 2%. But of most interest to me in this topic is in relation to the unemployment rate. In 2019, Ireland's unemployment rate was 5%. According to the ESRI, for 2020, it's going to be 16.8%. That's a tripling of our unemployment rate. And to put a human sort of tone on that, that's 405,000 people in Ireland who will be unemployed this year, compared to just 120,000 last year. And next year, too, is going to be an area where, even though there will be some recovery, presuming all goes well with vaccines and so on, it'll still be a high unemployment at the end of next year. And unemployment is a key indicator of negative psychological consequences. Now, there have been many recessions. This is isn't the first recession. There have been recessions around the world for many years, and there have been many, many large-scale studies. And one relatively recent review from 2016 looked at around 100 different recessions from all over the world, Northern Hemisphere, Southern Hemisphere, and over the past number of decades. And it generally is then confirmed through the empirical research when all these different researchers look at all these different recessions. Many of the recession research studies were conducted in light of the 2008 recession in Europe, in North America, and the rest of the world, but also other recessions like Japan's 1990s lost decade and Sweden's recession in the early 90s. And generally speaking, regardless of context, there are very few cross-cultural differences. That countries that undergo recession endure significantly higher rates of mental disorders. So typically, across 100 studies, the review of 100 studies published in 2016 suggested a tripling of rates of depression, which is quite dramatic. But there are also increases in substance abuse and suicidal behavior, which I'll mention a little bit more in a few moments. And within this picture, citizens who are jobless or who are rendered jobless are even more likely to have adverse outcomes. Let me just hone in a little bit on the 2008 recession, and in particular on the issue of suicide. There was quite a prominent study at the time, about 2011 or so, in the Lancet, a group in Cambridge. They worked out all of the unemployment rates over a long period of time across European countries, and then they worked out all the suicide rates for both the old European countries and the new European countries, taking account of changing EU membership. And combining all that data together, they provided very striking demonstration that when unemployment increases, so does suicide. And it was a very, very vivid tracking of one variable against the other. And what we sometimes forget about the 2008 recession is that for about a decade before that, unemployment across Europe had been declining. It suddenly went up again as a result of that recession, and so it was very vividly comparable to the suicide rate, which also was declining for the same period of time and suddenly started to go up again. For example, the unemployment rate in 2009 was 35% above the unemployment rate of 2007, whereas the suicide rate was increased by about 7%. And in the countries with the greatest unemployment, it increased more. So between 2007 and 2009, the suicide rate in Ireland, for example, increased by 13%. And Ireland and Greece were some of the countries where unemployment hit hardest, and suicide rates increased hardest there as well. Even more vivid were some research data published in the British Medical Journal around that time, looking at England in particular. And these researchers were able to put some numbers on the trends that really kind of speak to what we're going through with COVID now, when you actually look at it in terms of GDP and unemployment rates specifically. So these researchers looked at the 93 England regions for local administration. They looked at historical trends going back many, many years, and they checked the robustness of the findings in various ways. And so the headline findings were that the regions worst hit by unemployment had the highest increases in suicide. Secondly, the effects were stronger in men than for women, but I would say, even though it was reported as such quite heavily, they were also present in women. It wasn't simply just for men, it was also for women. Even within that little recession, that time window, around 2010, there was a small recovery in unemployment, and the suicide rate also went down that year, just a small bit. So it was a very clear mapping of one variable against the other. To give you some specifics, from the 2008 to 2010 period, unemployment rose from about 5% to close to 10% in England. And there were 1,000 extra suicides, 1,000 excess suicides compared to historical trends. The way the numbers were going, you would have expected 1,000 fewer suicides in that time period than were actually recorded. 846 of those were in men and 155 in women. And the researchers computed that for every 10% increase in unemployment, you would expect to see a 1.4% increase in suicide. And at the time, people were very struck by that, but it was a very robust statistical tracking of one variable against the other. They summarized it as follows, that 40% of male suicides, of men who took their lives during the years 2008 and 2010 in England, were attributable to that rising unemployment rate. If the unemployment rate had not risen, you would not have expected 40% of those suicides to have happened. So that's a significant consequence, and we are definitely going to have a recession arising from COVID. If you recall the ESRI report, an annual increase of more than 200%, a tripling of the unemployment rate in Ireland as a result of COVID. That would if the same effect were to happen this time in Ireland as happened in England in response to the last recession, that would be a massive increase in suicide numbers, around 30% increase in suicide numbers. So the statistics are frightening in the sense that what we know from all the studies about changing unemployment rates and changing consequences for mental health, that what we're going through now is going to have an effect on people who don't fill out questionnaires and studies and so forth, that don't tell us they're doing well, but people who live their lives and are in despair and need to be thought about in terms of public policy and service provision and in our response collectively to this COVID situation. It's not just unemployment that affects people. Sudden poverty, indebtedness, pension insecurity, all of these factors have been looked at in different studies and have been shown to have an effect on mental disorder. One study in Sheffield, in the Centre for Regional and Economic Research, they established that living in a house with a temperature of 15 degrees or below was associated with doubling of mental health problems compared to living in a house with the temperature of 21 degrees or warmer. So there's a big concern about fuel poverty in England generally, and the research suggests that fuel poverty is a statistical predictor of mental health outcomes. So it's important that we consider the economic damage caused by COVID in mental health terms, because there will be a big legacy on that. There are some positives in terms of this particular recession. There are some reasons to believe that we might bounce back better than in previous recessions. Fewer people in Ireland have emigrated as a result of this recession, so we have more workers on standby. The hospitality sector is easier to reopen than, say, the manufacturing sector, and there is possibly a psychological reason there too, that people will, when COVID is all over, people will be more anxious than ever to go out and use the hospitality sector. So the dismal economic outlook might not be exactly the same for this recession as compared to previous, but I would suggest that as psychologists, we urge people to be attentive to the mental health consequence of the economic damage that we are seeing in our country and around the world. This sort of takes nicely into the second topic, which relates to the scientific research on disasters and the impact of disasters more generally on mental health and on well-being and on people's outcomes. So for this second topic, I just want to summarize, I suppose, some of the research on that in particular. What is the impact of disasters and upheavals and crises and emergencies on psychosocial well-being, and what other impacts might we expect to see? So I'll just go through a few points on this literature, because I believe it's relevant and it's important. As has been said a bit earlier in the session, a lot of the COVID research is just coming on stream now, but there's also a whole lot of other research that is relevant, and it's important that we keep it all in mind. Okay, so one question a person might ask quite reasonably is the COVID pandemic actually a disaster in the strict sense of the term? People use the term disaster in all sorts of ways, but there is a science of disaster research. The United Nations, the European Union, and various other pan-national organizations have standardized approaches to this. There are all sorts of data collection efforts to track the occurrence of disasters and their impact. And there's a Centre for Research on the Epidemiology of Disasters in Louvain University, which is sort of the global leader in this, and the United Nations and other organizations plug into that database. And over 40 years or so, they've worked out, there's a sort of a standard approach. What is a disaster? A disaster is an event that causes the death of 10 or more people, so we certainly see that. A disaster is an event that affects 100 or more people, that's certainly true. A disaster is defined as an event that leads to a declaration of a state of emergency, that's true, or an event that leads to a request for international aid. And only one of those 4 criteria need to be met. Now, COVID meets all of them. So we're definitely in disaster territory when we talk about COVID-19. And if you're interested in some scientific advice on the matter, no less an authority than President Donald J. Trump in the United States has actually, despite his Twitter feed, has declared COVID-19 to be a disaster in the United States because under the Stafford Act, in order for states to draw down relief, emergency relief, the President has to sign a major disaster declaration, and he has done so on March the 13th for all the different states. So there's definitely a consensus among experts that we're looking at a disaster here. Sometimes psychologists talk about the difference between a natural disaster and a human-made disaster, and there may be some issues there. But others say that a natural disaster is kind of a misnomer because disasters arise from a combination of hazard and vulnerability, and when the two meet, you have a disaster. But vulnerability is the causative factor, and vulnerability is created by social conditions. So ultimately, all disasters are, in a sense, they have a human-made dimension. Anyway, we shouldn't get bogged down on that. The critical point to bear in mind in this is that there's a lot of research, and we won't go into it all here, but there's a lot of research looking at disasters of various kinds over the decades. There was a review 2 years ago in the journal Issues in Mental Health Nursing. It was a meta-analysis of 21 studies with large samples and control groups and robust mental health measures, clinically valid measures. So looking at about 45,000 people who had lived through disasters and had completed standardized psychometric measures of clinically diagnostic relevant variables. And there are significant impacts to be seen across cultures, across situations, man-made and natural disasters and so forth. And a general increasing, they reported an increase of around an odds ratio of 2.9 general psychopathology. So more general psychopathology, 3 times more general psychopathology because you lived through a disaster compared to other people. Naturally, an increase in stress and PTSD and so forth, and an increase in anxiety. So some other more qualitative or more sort of analytic reviews have reported that people who are socially marginalized are more affected by social upheaval, and communities are more likely to be impaired if they're composed of youth rather than middle-aged adults. So there's some issues there for us to bear in mind. Just a point to also bear in mind, Damien mentioned that I work with stress psychophysiology. There is also a reason, I suppose, to be concerned about the impact, the long-term legacy. After we have a vaccine or after we have herd immunity, whatever it is people are looking for, and after we have a bounce back of the economy, what is the legacy, the long-term legacy of all of this stress and all of this upheaval? And I think it's worth our bearing in mind because billions of people have been upended, and their lives have been upended by this crisis. So everybody's coping with a new reality, and stress is just another word for having to cope with something. So we're all carrying a load to some extent. Billions of people around the world are carrying some kind of load. And we do know that persistent or long-term stress, even in relatively small amounts, increases risk of things like heart disease because of the increase in cardiovascular function and cardiovascular coping, the disruption of cardiovascular homeostasis. So heart disease is a major problem at the best of times in a world where everybody is locked in their houses, engaging in sedentary behavior, and also engaging in emotional coping that elevates physiological arousal. You know, the knock-on effect on heart disease rates in the future might be worth tracking and might be worth anticipating. And there are similar problems in relation to things like inflammatory diseases. There's a lot of evidence that persistent stress contributes to chronic inflammation and alterations in immune function and so on. All the classic stress hormones, norepinephrine, feeds hypertension, it disrupts lipid function in the body, interleukin-6, C-reactive protein, other things, other stress hormones contribute to atherosclerosis. Catecholamines have been implicated in breast cancer. So this high level of stress hormone in the human population, the human herd, to use that term, you know, is going to have a consequence that will be measurable at a global level in population terms. And we need to bear that in mind as well if we're advising and thinking about policy. And there's some nice research coming out of the UK, and Mark Shevlin in Northern Ireland is leading on this. In the current issue, I think, of the British Journal of Health Psychology. And they've looked at the relationship between anxiety, COVID-related anxiety specifically, and somatic symptoms. And they're finding additive effects. So apart from generalized anxiety disorder, COVID anxiety in particular is adding to the somatic load on people's health. There are a couple of points I wanted to just make by way of wrapping up, but there are, I suppose we'll skip along because of time. The crisis really that faces us has many adverse effects. It affects people's mental health, it affects their physical health, and also undermines social cohesion, and all of that creates a fear. So some people fear the illness, some people fear the lockdown, some people fear the political instability and the rise of of discontent in the population. That is something that frightens me actually. So the potential long-term consequences for social cohesion are also something that causes stress, and as well as the aforementioned economic consequences. So we need to think about what creates that level of stress. Some of the factors that we know from research is that media exposure affects risk perception. News exposure in relation to COVID has been shown in a number of different countries, Italy, the United States in particular, to contribute to stress and anxiety and depression and so forth. And we also have this issue about how people cope with stress in different ways. Some people react to stress by lashing out at society and disconnecting and not following advice. Taking control of their personal situation because they can't control the world. And so they don't wear a mask, they don't adhere to guidelines and what have you. And in the future, they might not take vaccines because they just, that's their way of coping with the background level of stress. So population stress creates a load that affects all sorts of things, including altruism and pro-social behavior. And all of this is important for us to consider. So there's a large body of research out there that I think psychologists can bring to this issue and help advise on all sorts of ways to deal with the COVID crisis.
Great, thank you, Brian, and indeed thank you to the entire panel. You've really highlighted to me, and I'm sure anyone logged on and tuning in, the array of ways in which COVID as a scenario, as an ongoing pandemic, has affected a variety of groups across the country and indeed further afield. So thank you for doing so. I guess there's a bunch of questions. I really don't know if we're going to get through them all, but I'll try and cherry pick, and apologies to anyone I perhaps leave out. I'll do my best to get as many out to the panel as possible. First one in here is anonymous. Why didn't Damien just say www.thesciencebit.net? Someone in the studio has been really cheeky. I don't know who that is. We'll move on. The next one I think is directed specifically towards Dr. Burns and Annette. With much psychotherapy, counselling, etc. moving to online platforms, due to the pandemic. How do you feel this has impacted the efficacy of these services?
Myself? Yeah, I think looking at it briefly, I'm no expert, but the evidence suggests that online therapy is effective. But I think what would matter here is the training and the experience with it, because obviously our attitudes and expectations on both the client and the therapist side will matter there. And in this situation, it's kind of been forced on everybody rather than chosen. So I think, yeah, that's probably what's going on there, but I'm no expert on it, so I welcome any comments from the audience or my colleagues on it as well.
Yeah, thanks, Annette. My own sense is it might even be a little early to determine, the efficacy. It's possibly research that is either happening or perhaps ought to happen, just to evaluate how it compares.
Yeah.
Thanks to the person posing the question. Another question here, which might be applicable to a number of you, if not all of you, is, and I heard reference being made to various measures and psychological questionnaires that perhaps reflect different aspects of psychological distress or mental disorders, depending on the terminology. A person is asking what measurement tools were used to examine emotional responses or the social impact of the virus. Any to mention?
Well, for me, there was a range of stuff in the literature. There was those scales for anxiety or depression symptoms or general distress. There's also some studies about diagnostic data, and then there's also a lot of kind of self-report single item stuff. So, for instance, the CSO would have just asked people about how they felt about their life satisfaction, or have you been feeling downhearted or depressed, so kind of simple items like that as well.
Anyone else? I know I heard Brian mention it, possibly Kathleen and Dean as well. Any other questionnaires or measures that you feel are worthy of a mention?
Well, it's just Brian here. Number of the studies use generalized anxiety disorder scales to try to get at these variables. Mention was made of the study last week in the Lancet about people who were shown in the United States to have high levels of mental health disorders within 90 days of getting COVID itself. That study drew some negative commentary from researchers who said that the measures were not good enough in that study, that they were essentially looking at hospital chart records. So somebody would come along to a patient and write down whether they were distressed or not. It wasn't a thorough diagnostic approach. And that, in particular, they said adjustment order was particularly a problem. But adjustment order just means that you feel the person's reaction is disproportionate to the challenge they're facing. So it wasn't a thorough diagnostic. And that's important because that research went all over the world. And, it was reported in every news station, every news outlet in the world. And I think that what's behind the questioner's question is a very important point, which is that we need to be sure that these measures stand up and are robust, because they have consequences. Everybody's watching.
One scale that I've seen quite often in the literature is the Warwick Edinburgh mental well-being scale, which is used quite. It's a nice one. I've used it myself. But again, a certain element of critical thinking is needed within. Like, there's going to be cultural differences. There's going to be a lot of other macro factors that are going to influence any study, and especially because there's lots of cross-country studies that are happening now as well. We need to try and take into account that from a research methods perspective. So definitely, if you're trying to navigate some of these studies, and psychology is generally well placed to try and critique a lot of these points. So trying to inform, and that's one thing that we're trying to do here in the committee, is trying to inform what's actually happening and what the actual practices are. So critical thinking is a huge element when we are navigating a lot of the literature here.
Very good point. I know in studies that are occurring in the Dublin hospital arena at the moment, PHQ-9, which would be a depression questionnaire, the GAD-7, I think, is along the lines of what you mentioned, Brian, as well, and the impact event scale revised, which is a scale currently used in a variety of studies across the world to do with trauma symptomatology. But a lot of the questionnaires are actually quite negative focused, symptom focused, and I think sometimes it's important to try and capture protective mental health factors too, such as resilience or social connectedness or social support, etc. But a good question nonetheless. I guess it ties in with another one here, which is overall question on above is, do we need to be cautious about over-psychologizing or psychiatrizing, is actually how it's put here, natural human emotional responses? Anyone with insights around that?
Well, I think as we said as well, like it's a bit of distress is not unusual at the moment, and it's a good point that we don't need to catastrophize all of that. We need to certainly monitor the situation and, like Dean's saying, critically appraise the evidence that is coming out. But it is normal in this situation that we're seeing some distress. It's adaptive.
Mm-hmm. For sure. Okay.
Sorry, Damien, I think a point you could add to that. I mean, I absolutely agree with that and the questioner's point. A lot of how we should deal as a society with this involves political decisions and challenging and difficult political decisions. And there has always been a concern in crisis management that you end up blaming the victims. And so some of the discourse about how you can cope and how you can be resilient or how you're reacting, it almost locates the crisis in the individual, when actually, key government decisions about, regulations, lockdowns, policies, vaccines, all these types of things are equally important, if not more important. And some of the reasons people are vulnerable are because of social policies that have created poverty and vulnerability. So it's not, I agree with the question actually, it's not all about psychologizing it at the level of the individual, because that distracts us from some of the big things we need to do to improve our society, because some of the problems we're seeing are not individual problems, they're social problems.
A point well made, and it might connect to, it's steered me towards a related question, I guess, which for some reason I think Kathleen might have some insights on, but maybe I don't want to put you under pressure to respond, Kathleen, because it probably applies to all of you in various ways. What are the views of the panel on the psychological impact on artists, musicians, or indeed other career pathways who've been told to retrain for another or different career and job given the current circumstances and unemployment landscape?
It's a great question. And I guess if we link to how a lot of organizations and particularly small firms have adapted, a lot of that has been looking at, if my existing revenue stream has now been lost because of, how work has changed or whatever, I need to look at how I can recreate the business. And I think the big word that's been used at the moment is pivot. So it doesn't sound like an unreasonable thing to suggest people might do in the interim period. And I think the important thing is getting people to reflect on how they can use their skill set that they have to be able to, to adapt, to train, to gain employment in the interim, or look at how they can provide their existing skill set, but just through a different medium, because I think people are feeling lost without having access, like, the punter, access to their artists and their musicians and so forth as well. So I think it's about working with people to optimize what they can do, and that's where I think we tap into those things of the psychological capital, so. And I know that point about, like, I guess maybe how I'm a bit different to the other contributors is I'm a practitioner more so than an academic. So I will look to how can the research inform how we can optimize how we, work in the workplace and that. So I think that's why, what are the tools that are there that can help us, help the different populations who've been impacted to be able to adapt in this context. Sorry, I'm getting a bit windy there, but yeah, I hope that makes sense.
Not at all, it did. It certainly did to me. And I just want to thank you, Kathleen, for that, and also the rest of you guys, Annette, Brian and Dean, for a very, very interesting and imagination-capturing session.